speaker. And our next speaker is Dr. Lalit Raut. He is a hematologist, hemato-oncologist, bone marrow transplant physician, director of Aureus Institute of Medical Sciences, Nagpur. And his topic is crisis in sickle cell patient. So over to you, Dr. Lalit Raut.
Okay, thank you. Good afternoon. Are you able to hear me? Okay. Thank you. I am Amravati for inviting me for this talk. And are you able to see the slides?
Yes, sir. Please go ahead.
Okay. So my topic today is management of sickle cell crisis. We'll start with basics. What is sickle cell disease? We know it is an inherited disease. Abnormality is in the hemoglobin, that is in the red blood cells. At the protein level, it's the amino acid level, glutamic acid is substituted for valine in the beta chain. And this structural change leads to polymerization of hemoglobin S, that is sickle hemoglobin, under specific conditions, which leads to cascade of events causing decreased blood flow, then tissue hypoxia, and then leading to acute and chronic organ damage. It is autosomal recessive condition. There is abnormality, that is missense mutation at chromosome 11 level. Now this structural change leads to abnormal polymerization of hemoglobin S in the setting of abnormal environmental conditions such as hypoxia or acidosis or infection or change in the temperature, either hypo or hyperthermia. These red cells adopt structural changes, leads to conformational change, and if we study the fluid dynamics at the microvascular level, there are alterations causing mainly the blockade of the microvasculature. And then the cascade of events starts, which clinically present as acute or chronic organ damage. Acute will be crisis and chronics are chronic organ damages. Let us remember that the problem here is not just restricted to red blood cells. The chronic inflammation here leads to chronic platelet activation. There is endothelial cell activation. N number of endothelial and protein adhesion molecules are overexpressed. This causes endothelial cell adhesion protein activation, and acute phase reactants are chronically elevated. Overall, this what leads to is increased thrombogenesis risk, and there are microinfarction in the affected organs. So the abnormality here is not just red blood cells, but it goes beyond red cells to affect endothelial cells, platelets, and cytokine formation, and which clinically presents as the abnormality in different organs. So wherever sickle cell reaches in whatever organ, then we can have the manifestations. So these are all clinical consequences of sickle cell disease. Today we will be dealing mainly with acute complications, acute infections, anemia, mainly hemolytic crisis, vaso-occlusive crisis, acute chest syndrome, and many more. We know traditionally we have been learning from our MBBS days that different types of crises are there: vaso-occlusive or hemolysis, acute chest syndrome, sequestration, whether it's splenic sequestration or it could be hepatic sequestration crisis. So we will concentrate mainly on the vaso-occlusive crisis. Most of all, we know that these crisis episodes are precipitated by certain factors. We need to know these factors because we can avoid them in future, and we can reduce the patient's admissions in hospital for crisis admissions. So common precipitating factors, we have infections. We have viral infections are more common in our region than bacterial. Then extreme physical exercise, dehydration, especially in the summer season, physical stress, psychological stress. So children with sickle cell disease appearing for 10th or 12th examination, at the time of examination, few days prior to examination, they will have vaso-occlusive crisis. Alcohol, pregnancy, and any other condition which can cause hypoxia or acidosis are all the precipitating factors for this crisis. The bundle of care in management of sickle cell includes all these uh, sections, that is health maintenance, infection prevention, like uh, vaccinations and penicillin prophylaxis, pain management, that is for acute as well as chronic pain syndrome, and sickle emergencies will be highlighting all these things. And of course, because it's a chronic disease, it affects lungs, it affects heart, it affects brain, it affects kidney, it affects bone. So all the respective fields, that is ortho, nephro, and cardio and pulmonary people are also involved in the management of this disease. The most important slide which I want to highlight today is when I'm talking on this topic, and if we read anything on this topic, we must remember that whatever is written, whatever we are doing, this is more of a experience based rather than evidence based. That means there are less number of clinical trials answering each and every question, but whatever is going on traditionally, that we are following. So when we have a child with acute painful cell crisis, we must remember that it is an acute medical emergency. We assess the pain using appropriate pain scoring tool. So this helps, we usually use Wong-Baker face rating scale. This helps to assess whether the drug is acting or not, that is the analgesic, and whether we need to increase its dose, or we need to add another analgesic, that is for step-laden pattern of analgesia. So that's why this scoring scaling of pains is very important. Second thing is, we must always remember to administer analgesia as early as possible. In fact, many times I advise people to consume analgesia at home and then don't wait for analgesia to be administered at the hospital, because earlier we start the analgesia, the duration of crisis pain, duration of crisis syndrome reduces. Apart from clinical assessment, that is TPR, BP, and saturation, we should always ask for the precipitators, and we should always look for any alternative diagnosis of pain. For example, if a child is having pain in the hip region, then in addition to just vaso-occlusive crisis causing pain, we must also look for if there is AVN or any other infection. So analgesia, fluid replacement, and avoidance of the treatment of the environmental precipitator are the mainstays of therapy. So let's look at one each. First is hydration. Why do we hydrate people? That's because intracellular dehydration of red cells is associated with increased rate of sickle cell hemoglobin polymerization. So if we rehydrate the red cell, then the red cell polymerization of the hemoglobin reduces. So less polymerization, then the crisis will be lesser. Then question comes, what kind of fluid should we use? That is normal isotonic fluids or hypotonic fluids. So we have evidence from in vitro studies. What they did was they studied normal red cells exposed to hypotonic fluid, and they found that the red cell membrane stiffness reduces when the normal hemoglobin containing red cells are exposed to hypotonic fluid. Similarly, if what they did was they exposed the normal red cells to isotonic fluids there, and then they found that the stiffness is increased. the transit times through microvasculature is increased. And in hydro studies, they do this in a human capillary system model called as microfluid model. So if the red cells are exposed to isotonic fluid, then the transit time is less. So accepting this principle in sickle cell patients, we use hypotonic fluids. What route we should use for mild crisis? Oral rehydration to be started at home, and if the crisis increases, then we shift to IV. Or if the pain is very severe, or patient is having, because of liver issues, if patient is having vomiting or obvious volume depletion is apparent, then parenteral rehydration is preferred. While doing so, we should remember that aggressive hydration is can cause hypervolemia, so and that should be avoided. And that's because patients may have any other conditions which may precipitate pulmonary symptoms. For example, if patient is hypoalbumic because of liver disease, then we usually try to avoid hypervolemia. Another practical issue is when we are hydrating with hypotonic fluids, then and if we are simultaneously administering packed cells, then they are not compatible. So you need to use another IV site. Next step is analgesia. Mild pain, if patient calls you and starts, child has started having mild pain, ask them to start analgesics, starting with lowest, that is paracetamol, and then gradually increasing according to the severity. If the patient visits hospital, you remember that it is an emergency. We apart from other routine evaluation and hydration, we assess the pain level, treat it. If patient was already on opioids, we don't withhold it, but we try to increase it up to other level. We assess the pain control frequently. This is especially important to reduce the medication or to increase the medication, as well as to control the side effects like respiratory depression. So all these analgesic, if mainly opioids can cause respiratory depression. So to avoid that, we just keep a watch. That is, we frequently reassess it. Mild to moderate pain, we use paracetamol. NSAIDs should be avoided. Moderate to severe, opioids are the first line of treatment. What we use is morphine, or if it is not working, then next step, we usually go on to fentanyl and other drugs. Next step is oxygen therapy. Important point is pulse oximetry to assess the SpO2 may not be reliable in certain conditions, especially when in severe episodes. Why? Because sickle cell RBCs have decreased oxygen affinity and it will not give an accurate reading. Moreover, the increased sickle cells RBCs have increased unsaturated hemoglobin in the arterial blood. So the pulse oximeter reading may not be reliable. So in that situation, arterial blood gas analysis is best. In our institute, we use ABG only if patient is having severe symptoms. For mild to moderate, we usually use pulse oximetry only. Oxygen therapy, we know that it is used routinely, but usually it is not indicated. And why not? Because it has been shown that oxygen therapy has no effect at all on the duration of brain crisis. Even in acute chest syndrome patients whose PO2 is good, then it has been found that it is of no use. So unnecessarily we are wasting the oxygen. Moreover, increased oxygenation in the blood will suppress the erythroid production, and this later on, that is after discontinuation of therapy, leads to rebound crisis. So oxygen therapy should be used only if indicated clinically. What is the role of transfusion? There are different kinds of transfusion, that is simple transfusion or exchange transfusion. Simple transfusion means we just transfuse the blood, and in exchange we remove something, and then in exchange of that removal we transfuse this PRC. When should we transfuse the packed red cell. Usually, there are two conditions here. Some people advise it blindly use 8 hemoglobin as the criteria in adults, or in some studies say that we should know the patient's baseline hemoglobin, and if the hemoglobin drops more than 2 from that, then we should use the simple transfusion. So for example, patient's hemoglobin is around 9 or 10 during routine checkup, and if patient has presented to us now in acute crisis, and now if the hemoglobin is 7 or falling, then that is the indication of simple transfusion. If we don't have the reading, then use 8 as the criteria, as we use in all other ICU patients. And how much to transfuse? Again, the target hemoglobin will be the patient's baseline hemoglobin value. So it is better to always to know what is the patient's baseline hemoglobin, that is hemoglobin when the child is asymptomatic. Exchange transfusions means we remove the patient's sickle cell blood and we transfuse the sickle negative blood. We consider this in a prolonged refractory vaso-occlusive crisis. And another condition is the patient's hemoglobin level should be near normal. So then only we can exchange it. But if the hemoglobin level is less, then only option is simple transfusion. How much to transfuse? Again, here we monitor the S percentage, and less than 30 to 20 is the target value. There are other conditions also which present with pain. So like hand, foot, mouth, splenic sequestration, cholelithiasis can cause acute pain, priapism, AVN, right upper quadrant syndrome. Basically, for all these syndromes, pain management principles is the same. So another complication what we see is sequestration crisis, usually seen in children less than 2 years of age. So pediatricians usually see these complications here. Suddenly the spleen size increases and patient becomes anemic. The spleen being a spongy organ sucks all the blood and can cause circulatory collapse and death. It is more common with sickle cell disease than with compound heterozygous status of S and C hemoglobin. Mainstay of therapy, again, IV fluid, cautious blood transfusion. Here we don't keep the target of baseline hemoglobin, because what is observed that once the crisis is reducing, suddenly the spleen size starts decreasing and the whole blood is pumped in the circulation, and then which can increase the hemoglobin or can cause hypervolemia. So here we just try to give transfusions to maintain the adequate oxygenation. So it could be 6 for some patients, it could be 7 or 8 for some patients. If the child has recurrent episodes, then splenectomy is the treatment. But nowadays, with good response to hydroxyurea, I usually advise splenectomy only if on optimal medical therapy patient is having 2 or more episodes of splenic sequestration crisis, then splenectomy is indicated, but not without optimization of hydroxyurea therapy. That is, at least we should see the response on 30 milligram per kg per day. If that reduces the episodes, then well and good, avoid splenectomy. If not, then go ahead with splenectomy. Another complication is acute chest syndrome. It is one of the leading cause of death, defined clinically as acute onset of fever, respiratory symptoms, and new infiltrate seen on X-ray chest. Commonly, it's because of infection. Underlying pathology could be fat emboli or lung infarct. We treat it as if both or all the three conditions are present simultaneously. So we treat infections with antibodies and acute chest syndrome as per other guidelines like blood transfusion if required. fever is very important in patients with sickle cell disease. Why? Because mostly they are hyposplenic. So it is like managing fever in a splenectomized patient. So even the ultrasonography is showing spleen normal or less smaller size, even it has not reached asplenia. There is functional asplenia. So that's why we consider sickle cell disease patient with fever as any fever coming in a patient with splenectomized patient. So it is an emergency. So we assess patient clinically, do all the lab works, look for site of the infections. We give IV antibodies as per the criteria and should be managed in hospital uh, if required in ICU. So fever should be considered as an emergency and need admissions usually. No slide, no management slide will be there without slide on prevention of the pain crisis. We usually advise all these people, but we need to stress them in each visit. So whether child is consuming adequate amounts of fluid or not, ask the parents to monitor that. Then we try to talk to the school teacher also, and we need to educate them that how hydration of this child is important to them. Patient should always avoid visit to higher mountains and mountain conditions, because the change in height and as well as pressure can precipitate the crisis. Also extreme temperatures, genetic condition, screening, genetic counseling are all part and parcel of the management of this. There are newer drugs. All patients keep on asking what are the new drugs coming in sickle, what is the new therapy coming in sickle cell disease. From last 2 to 3 years, L-glutamine, voxelotor, and crizanlizumab. These drugs received FDA approval in Trump era. Don't know why glutamine was approval was pending so long and suddenly it got approval. All these drugs are useful only for prevention of pain syndromes. They are not much useful in management of acute conditions. These are indicated with or without hydroxyurea. L-glutamines, it is specially said that these drugs, these medications should be used only after optimal use of hydroxyurea. Then only these are tried. So to summarize, if possible, identify and treat the underlying precipitating factors of crisis, because we usually forget to that. We usually concentrate on treating the current condition, but precipitating factors should also be addressed. Hypotonic fluids are better. Oxygen therapy only when indicated, and avoid delay in administration of analgesia. And when on analgesics, especially morphine or other drugs, it reassessing the patient every 30 minutes for severity, sedation, vital signs, and respiratory is important. Thank you.
Thank you so much, Lalit sir. Thank you for the very informative talk you have given. And you've really given a very good information on VOC and how to manage the crisis. So, and I must thank you and Ashish Ganjre sir for joining us from Nagpur. Thank you.